participating. This is a basic course. Some of you may find it too basic. Some of you may have questions which you may feel are very basic. So we wouldn't mind any question. Don't find any of your questions ridiculous or below par. We'll be able to answer. So do ask, because that would be the question. There are many others wanting to ask and have not asked. We are a little late, but we have time cushioned, and we also have time at the later part of the day. We are also organizing sawbones for those who would like to do them at the end or see them on a couple of tables. They should be here by 11 o'clock. So we will start our meeting with the, you'll see that there is a flow to the entire course. And the other thing is, I must welcome the faculty from the UK. It's largely an Indo-UK course. So we have faculty from UK and faculty from India, and most of this faculty has been associated with the Royal College of Surgeons. Normally you wouldn't get so many of them traveling together for a basic course anywhere. So we are grateful, and we hope to compensate by showing them the Taj Mahal. I would get the course kicking with the first talk by Dr. Gupte, and he would talk about consent and pre-op planning. This is crucial, because if you have no consent, you can do nothing. So Dr. Gupte, please, from UK.
Good morning, everyone. Sanjeev, Ajay, thank you very much for inviting me to speak today. First of all, just so that we know our audience, how many of you have done on your own more than 50 total knee replacements? One. How many more than 20? And how many have assisted in total knee replacements? Okay, good. So that's ideal, because that's the kind of pitch of my talk. So, one of our main aims in total knee replacement is to operate on the right patient at the right time, to insert the right prosthesis with the right technique, and hopefully that will give us the right outcome. How many of you plan your total knee replacements the day before surgery? One, two. How many on the day of surgery? Any people plan it a month before surgery? You've got to be honest. One. Okay, so when I was a trainee, about 10 years ago, I thought I was being really smart by planning my total knee replacement the day before surgery. I looked at the x-rays, looked at the letters for the patient, and I thought, that's great. But as I've become a consultant, and I've had the odd complication, and in fact I've defended some colleagues who are being sued for complications, I realize actually that the planning process should take place right from the day one when you meet the patient in the clinic. And if I'm going to summarize planning, this is what you need for your exam. Is there a deformity? If so, how are you going to correct it? Is it going to be soft tissue correction, or are you going to need a bony correction before you do the operation? Is there any ligamentous laxity? Again, will you be able to tighten that up with your prosthesis, or will you need a constrained prosthesis? And is there a bone deficiency that you need to compensate for? Now that's the technical aspect of planning. But I'm going to make no apologies for starting with the very basics of planning, which is really selecting the right patient, a proper preoperative medical assessment in order to mitigate against potential complications. The clinical examination, I cannot stress how important the clinical examination is, even before you get to the radiological examination. The selection of an appropriate prosthesis based on all of this, and then, as I've said, a lot of litigation, particularly in the UK, is because of an inadequate consenting process. So, again, for your exam, if someone says, what are you trying to do with a total knee replacement? The idea is to decrease pain, to restore function, if necessary by resolving deformity, and to reduce disability. And the technical goal of our total knee replacement is to implant a well-aligned prosthesis in a well-balanced knee with linear patella tracking and achieve infection-free healing. And if we've done all of that, you're going to be a great surgeon. But it all starts with a history. Is it the right patient? If you have a patient that can walk more than 5 miles a day and gets very little pain at rest or at night, you should be thinking twice before suggesting a total knee replacement. Have they had previous steroid injections? Because if they've had 7 or 8 steroid injections, you're thinking there may be an increased risk of infection here. Do I need to mitigate against that with prolonged antibiotics or with other measures? And don't forget their comorbidity. Diabetics, hypothyroid, and inflammatory arthritis are all going to contribute to the way you plan your operation. If they're on warfarin, what are you going to do? Are you going to take them off warfarin and give them low molecular weight heparin? Do they need an IVC filter because they've got recurrent pulmonary emboli? All of these things you cannot do after the operation. And this X-ray just reminds me, this I thought was a technically well done knee replacement, but the patient kept getting swelling, and he got swelling, funnily enough, in the other knee, and he had diarrhea, recurrent diarrhea. Multiple microbiological tests, including biopsies, synovial biopsies and washouts, showed no microbiological infection present, but he did end up showing he had a nickel allergy. And even though I took a reasonable history, and he had no history of nickel allergy, his daughter did. And perhaps in retrospect, I should have checked for that, and I should have put in an oxinium knee replacement. But it just highlighted to me the fact that you should ask them, are they not allergic to drugs, but are they allergic to any drugs or metal substances? So, we know the absolute contraindications for total knee arthroplasty. One slightly emotive contraindication is whether the patient has an asymptomatic bacteriuria. What do you do? These days, if they've got any bacteriuria, I would like it treated with antibiotics before I perform the knee replacement. Now, the recurvatum deformity secondary to muscular weakness, here's a polio child. This is a very difficult issue, and in the old days, that would have been an absolute contraindication to total knee replacement. But perhaps you could argue for some kind of constrained knee here, although you will be causing weakness, further weakness of the muscles. And there are some relative contraindications which I've listed there. Clinical assessment. Before you get to the radiology, this will tell you a lot in terms of planning your operation. Is the deformity correctable? If so, how are you going to correct it at operation? And do the patient have multiple scars? If they have multiple scars, how do you make your incision? If they've got a that's a transverse scar that you've seen there in that patient. But if they've got multiple longitudinal scars, which scar should you use? Anyone? The lateral most. Why is that? That's right. So you want the biggest skin flap with where the blood supply enters medially. And again, you will not diagnose PCL insufficiency on an X-ray unless you have assessed the patient first. So this is the minimum radiological investigations you should request: weight-bearing AP lateral and skyline patella views. But in addition, in some patients, you might want a Rosenberg view, and ideally, and in an ideal world, you should really have a long leg standing view, although resources dictate that many of our units, we won't be able to get that for every patient. And sometimes you want CT to assess bone stock and MRI to assess the competency of the ACL or PCL. So here's on the right, top right, you've got a non-weight bearing view and a weight bearing view. And I don't think it I need to tell you that you must have a weight-bearing view in a patient for this reason. This patient would have been sent for physiotherapy. In fact, he was sent for physiotherapy because the GP requested AP lateral views of his knee, and it came back as very mild degenerative change, and so the patient had physiotherapy. And when they came to our clinic with rest pain, night pain, and unable to walk more than half a mile, and we got a weight-bearing view, you could see that there's a massive amount of medial joint space wear. But also on the AP, you can check for osteophytes and bony defects and other deformities. And the joint line. There are some measurements to assess whether the joint line has been altered on the AP scan. The lateral view will give you an idea of the patellofemoral wear in the joint, but also when I plan my surgery, I draw these lines in order to know where my entry point for my femoral and tibial drill is if you're using a tibial intramedullary alignment. And very occasionally you have a flexed femur and your entry point is much more anterior than you think. And if you go in too posteriorly, you'll end up coming out of the anterior cortex. The skyline patella view will give you an idea as to whether the patella is tracking laterally and how much wear there is on the patella. And again, it may allow you to plan whether you're going to resurface the patella or not. The merchant view, which I've illustrated there with the diagram, is an excellent assessment of patella tracking because it's done with the knee at 45 degrees rather than 60 degrees, which is what a skyline view would be done at. So you've got a history, you've taken an excellent examination, and you've got the right radiological investigations. Check yourself before you decide to recommend a total knee replacement to the patient as to whether other alternatives might be appropriate, such as osteotomy. And this was an old headmaster of mine who had a open medial meniscectomy in 1975, and he was an ideal candidate because he had an intact ACL, full range of movement, an extremely active 62-year-old man. So he was an ideal candidate for a unicondylar knee replacement. But once you've decided that you want to perform a total knee replacement on the patient, you need to have an idea of the goals in your mind before you actually embark upon it. And the goals are to restore a neutral mechanical alignment of the limb, to preserve or restore the joint line, to balance the ligaments, and to maintain linear patella tracking with a normal Q angle. So this is the diagram you need to know for your exam. And what you have here is the anatomical axis of the femur and tibia, which is the medial intramedullary part of the femur and the tibia. And there's the mechanical axis, which passes through the center of the hip joint, the center of the knee joint, and the center of the ankle joint. What's that angle between the mechanical and the anatomical axis? Anyone know? It's about 6. Well, actually, if you measure it, it's probably a little bit more than that. It's 6 to 9 degrees. But, and I'll come to why most of us do a 5 or 6 degree valgus cut, despite the fact of that angle being slightly higher in a minute. And in the tibia, the mechanical and anatomical axes are coincident. But when you have tibial bowing, and in the Asian population, we have a lot of Asian ladies, but you have obviously even more, perhaps with a history of rickets, the tibial bowing becomes very important because the anatomical axis of the tibia will be very different to the mechanical axis, and you have to take that into account. So the tibial joint line is typically 3 degrees of varus compared with the perpendicular subtended from the mechanical axis. And most of us, and there is some debate about this, most of us cut our tibias at 90 degrees to the intramedullary axis. So you end up actually cutting the tibia in a tiny bit of valgus, in fact 3 degrees of valgus. So you end up with an extension gap that's slightly 3 degrees of valgus, which is why you compensate for that by using a 5 degree cut here, even though technically you should be using a 7 or 8 degree cut. But also you end up with a trapezoidal flexion gap, which means that your tibial component needs to be 3 degrees externally rotated in order to compensate for that flexion gap. Now, when I ask my trainees, why do we externally rotate the tibia 3 degrees? A lot of them say it's to help patella tracking. That's the secondary consequence. The reason you externally rotate the tibia is to restore the flexion gap because of this anomaly. So with all of those things in mind, you get a full-length AP radiograph, and you can see in this patient that the mechanical axis is passing well medial to the medial compartment. Where should the mechanical axis pass? Is that normal or abnormal on the right side there? Any idea? Should it pass right through the center of the knee joint? Little bit medial. Anyone know what that point is called? Fujisawa point? It's about 60%, 40% medial to lateral. Okay? So your mechanical axis does naturally pass very slightly through the medial compartment. But in this patient, you can see the anatomical axis is passing well medial. And in fact, in this patient, look at this. So in your pre-op planning, you're going to have to think about what you're going to do about this femoral deformity from a malunion. Is that going to be corrected preoperatively or intraoperatively? But you need to think about that, because otherwise you're not going to restore the mechanical axis properly. So other radiology, I mean, it's sometimes useful to have a Rosenberg view because it gives you an idea of early joint space narrowing. And in young patients with a history of osteochondritis dissecans, occasionally you can have quite a large bone defect. If you're worried about soft tissues, whether it's PCL, MCL or LCL, really your clinical examination should give you an idea. But if you would like a secondary assessment of that, you can do stress views. And as I've mentioned, the CT scan is good for bone stock, and the MRI scan if you're particularly interested in the ligaments. So here we go, pre-op plan, varus knee. Sir, do you want to tell us what's going through your mind in this? This is a weight-bearing view, yes, standing. So in your pre-op plan, what are you thinking? I've drawn some lines there for you to help you. So this is a typical Asian patient with very bowed, unfortunately I didn't have a long leg view on him, but a very bowed tibia. So if you don't be careful, how will you place your tibial component? Where's it going to tend to go into varus or valgus? Yeah, it's going to go into varus because, again, if you don't, this is where your ankle is. If you do an intramedullary, for example, you'll end up with your stem going in here, and you'll end up with a varus cut. So you've got to be very careful about that. So you use an extramedullary guide. You realize that it's going to be a very asymmetric tibial cut. So I always check based on these lines. So that's a perpendicular to that. I always check based on these lines whether the tibial cut is going to be symmetric or asymmetric, because after I've cut the tibia, I have a look at the tibia to see, in this case, the lateral side will be much thicker than the medial side. So it's a secondary check. And although you may not think it, you may need wedges. You may not. But at least have them ready, particularly in your really bowed patients with marked medial deficiency. So here's bilateral, and it didn't need wedges. You did very well. So, the next is a valgus knee. Sir, what's going through your head on the valgus knee? Any ideas? Okay, so soft tissue balancing. What kind of soft tissue balancing are you thinking about? What structures are going to be tight here? Lateral structures are tight. Okay, so if your lateral structures are tight, what might you need to release? ITB. if it's tight in flexion or extension, would you release ITB?
We have to release the extension, and for flexion we have to release the posterior capsule, lateral capsule.
Okay, anything else you might release if it's tight in flexion? Popliteals. Okay. All right. So you've got soft tissue. But even before you get to the soft tissues, if we go through the pre-op planning for this patient, what are the pitfalls here? We said that in the varus patient, the tibia can go into the, varus patient, the tibia can go into a lot of varus.
Full X-ray of the femur.
Why would you get a full X-ray of the femur?
Is there any abnormality in the weight-bearing axis of the...
Absolutely. So you should get a long leg view. Okay. And in terms of your femoral component, what is the big danger here in the... Yes, sir.
There could be loss of the lateral condyle of the femur in the
Yeah.
varus knee.
Because whereas in the varus knee, most of the wear is posteromedial on the anteromedial on the tibia, in the valgus knee, most of the wear is on the femur and is posterior, so it's a flexion type wear. So what happens to your femoral component if you use a posterior condylar reference point?
Because it goes in the valgus, it should not consider the condyle at all.
It doesn't go into valgus, it goes into...
There was a loss of the condyle.
Yeah, so if we go back to this diagram, if the posterior femoral condyle on the lateral side is deficient and you're using a posterior reference point, your femoral component will go into internal rotation. So what you need to do is either use a white side line or you use build-ups on the posterior femoral condyle. I prefer to use the white side line and the perpendicular to that.
We can go perpendicular to the tibia, we will cut off.
You can if you've cut the tibia first, yes. But I think if the white side line, the epicondylar axis is a more accurate measure because if you rely on a tibial cut, you're relying on yourself as opposed to the patient's original anatomy. So, and the other thing with the valgus knee is, someone mentioned the lateral structures are tight, but the MCL is not necessarily incompetent, but it's certainly stretched. So the main thing is, don't take too much of the tibia, because you'll create more MCL insufficiency. So take as little tibia as you can get away with, perhaps 8 millimeters off the medial side. It depends on your prosthesis, of course. John?
What angle do you tend to cut the femur
In a valgus knee, I cut it very slightly more valgus than, I usually cut it about 6 or 7. Yeah, because again, you don't want to overcorrect. Okay.
Is it type 2 valgus knee? Because this cause of the valgus is the bone loss.
Yes.
Too much ligament laxity on the medial side.
Yes, but even in a 30-degree valgus, the medial collateral ligament is often competent, and if you get your components right, and I actually put in a posterior stabilized for the severe valgus deformities, you often don't need to do too much. You need to release a bit of lateral, but often you don't need to go to a constrained prosthesis, because sometimes people say, so if we go back to this patient, and unfortunately I haven't got a post-op x-rays, but if you go back to her, a lot of people say on that right side you might need a constrained prosthesis. But in fact, if you get your components right, you often don't.
Yeah, but you would use a PS.
I would use a PS, yeah. I mean, there isn't a lot of evidence for it, but at least it gives you a little bit more stability in that plane. Now, John and I were discussing this earlier. If you're really going to want more stability, you should put a constrained in. But I think if you can get away with the PS if you put it in right.
How do you do the IT band length thing by pie crusting or?
Pie custring on the tibial end. I use a 15 blade, and I actually, so usually it's tight in extension, and I put in the 15 blade and I just make a little cut by rotating it until you get enough release on the tibial end. Yeah. Okay, so next one. Anyone want to have a go at this one? So this is a refugee from Afghanistan, shrapnel injury from bullet wounds. I'm going to pick someone now. So in terms of, we're talking about pre-op planning here. What are you thinking in this gentleman? We've been given a bit of a history. Shrapnel injury. He's actually quite young. He's 58. There is bone deficiency, isn't there? Where? In the femur, yeah. And he's got shrapnel in. So I've given you the first part of the pre-op plan. We did a CT scan. It looks quite scary, actually. So what are you thinking in terms of your preparation? What would you have ready? What in terms of equipment?
Why you don't have weight-bearing long X-rays in all of
We do. Is that I have got weight bearing. It's just that
it gives a very good
you're absolutely right. That's why I said right at the beginning you should get weight bearing long leg views.
Problem is, Jim, as we've become more modern and gone to digital X-rays, a lot of the systems will not give you weight-bearing long film.
Yeah, they won't give you weight. In fact, what we have to do is get a CT scanogram, and they're not weight bearing. So, that's why I said there are limitations in every hospital. But if you can, you should get a weight bearing. And in fact, some people say you should get a standing single leg weight bearing view. Anything else? So what would you have ready? I mean, you've got. So you might need constrained knee. More than a constraint, you might need stems and wedges, mightn't you? Okay. Where do you think ligamentous laxity is going to be? Yeah, I mean, so he may.
Tumor is coming more anteriorly than the upper end of the tibia. It might cause the recurvatum.
Recurvatum, yeah, so you think he's got ligamentous laxity as well. Okay. So I had for him, I had stems, wedges, a constrained knee ready as well, and I was ready, I had the whole lot. He ended up having a primary actually. Okay. And he's doing very well. And the other thing, I gave him prolonged antibiotics because I was scared of the shrapnel. Okay, so the other thing about pre-op planning is, should you use a PCL sacrificing or retaining? Now, I'm going to speak about this at the main conference, but really to summarize, the jury is out and it's surgeon's choice, except in situations where the knee is clearly PCL deficient. Someone mentioned recurvatum. You should be able to do a posterior draw test on all of your patients. If there's severe valgus deformity, before thinking about the constrained knee, think about doing a PS. As I said, if you put it in right, most of the time you get away with it. And the other thing is, intraoperatively, check for mid-flexion instability. So don't just check for varus valgus as you do in extension and flexion, but at 80 or 90 degrees, check for a posterior draw. And if you're getting a massive posterior draw with your cruciate retaining, I change to a posterior stabilized at that stage as well.
How do you check the intraoperative mid-flexion instability?
Posterior draw. I do a posterior draw with the trials in. And if you've got a trial that's reasonably snug and tight in extension, you shouldn't be getting a posterior draw.
How many of you would do that? Mid-flexion instability on the table. You do that? Common? Every time. Every time. Yes. Every time. I think you do that every time. So once you put the trials in, that's the reason that you do a posterior draw. Check whether it's stable.
And there's some evidence now, really over the last 5 years, that if you do have mid-flexion, and what you can do is get how the studies have done it is they've done stress kneeling views post-operatively, and they've seen that the PCL is incompetent at 80 degrees, and those patients seem to have instability or discomfort when they're climbing and descending stairs. So there is a functional consequence to mid-flexion instability, which is why you should be testing for that intraoperatively, and you just change the prosthesis.
The mid-flexion instability, from what you just said, it would seem that you would associate it with the competency of the PCL, but it's absolutely clear that mid-flexion instability as a on-table phenomenon can be seen in a PCL sacrificing knee as well. In other words, mid-flexion instability is a phenomenon which is also correlated with collateral tension in the collateral ligaments.
Yeah, you're absolutely right. I mean, the collateral ligaments do provide secondary restraints both to anterior draw and posterior draw. And yeah, I mean, if you've got mid-flexion instability with a posterior, with a cruciate sacrificing, you need to think about it. But generally, if you have that, you'll get instability in flexion and extension as well.
Yes,
do you not think?
And the reason it's called mid-flexion is that it's not just to be tested at 90 degrees or in extension, full extension, but in the in-between range, typically from 30 to 60 degrees, because that's when the instability reveals itself. In full extension, it could still look a stable knee. At 90, it could look a stable knee. It's in the mid-flexion range that it becomes unstable, and that's why it harasses the patients in activities like stair climbing or as they are getting out of chair, because that's when suddenly the femur seems to slide forwards onto the tibia, and they feel a sense of imbalance at that moment. But that's a very interesting concept and probably a topic for a separate lecture.
Yeah, and in fact, if you... Sorry. Yeah.
What do you think? What's the cause of mid-flexion instability? Is it a higher joint line or there's some other reason? Why this happens?
Short answer is we don't know, and we've had a couple of... PCL insufficiency is one of them, so you could... In the sacrifice knee, collateral ligaments, but yes, you could have raised the joint line as well.
That could be one reason.
Yeah.
I'll venture to address that question
Yeah.
in my lecture. In the selection.
But you can, in your post-op films, you can have an indication of that on the lateral. So if the tibia sag back on lateral at around about 80 degrees, you know that your PCL is insufficient. Okay. So, moving on to consent, and I know I'm speaking to a mainly Indian audience, and I think you are now undergoing the kind of transition that we underwent about 15 years ago, where patients are the boss. They are demanding, they are very middle class, well-off, educated patients who would like to know why they're having the operation and what the risks are. And if you don't tell them, you will be sued. So the first thing is, what is the consent process and when does it start? When does your consent start, sir? When do you consent the patient? From day one. Quite right. I mean, most of us have the consent form signed on the day of surgery. But if you go to a court of law and there's something gone wrong and that's the first time you've seen the patient and you say, well, they signed the consent form, the patient can plead duress, because on the day of surgery it's very difficult for people to say no. So the consent process starts on the day of your first consultation and certainly on the day when you list the patient. And here are the BOA guidelines for the risks. I'm not going to go through all of these, but needless to say, you must explain every risk that is greater than 1% and every serious risk that could lead to serious loss of life or limb or quality of life that's below 1% as well. So I do actually consent my patients for death and amputation, but I don't put it that way. I say there is a small risk to your life and limb, which is extremely small. It's actually 0.25 to 0.5%, which is not that small. But you must explain that as well. And we did so the NHS obviously pays out a lot of compensation, and one fortunate offshoot of that is that we have good data on the compensation claims that have been paid out in the National Health Service in the UK. And we did an analysis of all the compensation claims, and here you have them. So we've got litigation success rate against the type of complication. If you leave a drain inside a knee in the UK, that is an automatic payout, and it's around about £30,000. But this is an interesting one, the wrong prosthesis. Now, that was a bit of a surprise to me. Now, if you use a right-sided prosthesis in a left-sided knee, then that's understandable. But one thing experts can determine on a post-operative X-ray is whether the prosthesis is oversized or undersized, or if you've notched the femur. And then that can be a technical error, and that has a higher likelihood of success of litigation there. Malalignment is another one. So you get a long-standing view post-operatively and say that was a gross malalignment, doctor was negligent. So, in conclusion, it's a very successful operation. Depends on who you look, the literature, but 90% of patients generally pleased. Maybe in some of the case series, 20 or 30% of patients are unhappy. But in terms of quality adjusted life years, it's one of the most successful operations in the whole of surgery. But it does require adequate pre-op planning, and adequate consent right from the beginning, which starts, as always, with the history and examination rather than radiology. So when I'm not operating, in fact, my office looks out onto Lord's, and I go to Lord's. So sometimes, if you are ever visiting the UK, you're very welcome to the Wellington Knee Unit, which is where I work, and at St Mary's, and we'll maybe take you to Lord's at the same time. Thank you very much.
Can still take. Any other questions for him? I get a feeling that some of us still may not be sure what is mid-flexion instability. Is there anybody who is doing a knee replacement and is not clear about mid-flexion instability and would like to know? I think there should be no hesitation in saying yes. You can put up your hand, because I, for one, still don't know exactly what's going on. So what happens is that there are a few people who are doing more, who have suffered this in the post-op, and there are a few who can be more communicative, but somehow I feel there would be at least 30% who still are not aware. Now the point is that it is often said that a knee replacement, the results of a knee replacement are far better from the point of view of a surgeon than from the point of view of the patient. And the reason for this in most instances is perhaps mid-flexion instability, where X-rays will still look very nice, AP and lateral views, but patient keeps complaining of pain. There could be swelling, there will be bogginess, difficulty in going up and down stairs or getting up out of the car from a chair, etc. Now this is very important, and as you just heard, that if we have to assess mid-flexion instability on the table, and if it is not done in the whole range, in extension the posterior capsule is tight, there's no point demonstrating to your fellow in extension, look what a stable knee. Also in 90 degrees or more, look how stable, because the collaterals will take up the position. You've got to do it at 40, 60, also at 30, 60, whatever, in between, to see how, and then the pull test as we just heard. Please, this is an important take-home message. Second thing is, we must thank you, because he said a 58-year-old is young, so I am to be born next week. Well, not really 58. Thank you. But nonetheless, we move on to Mr. John Hollingdale, who's going to speak about anatomy of the knee, covering layers of the knee. John's been around so often that we are considering a special citizenship of India for him soon. Thank you, John. Thanks.
Thank you very much for that very kind introduction. I hope I'm not going to teach you how to suck eggs, just talking about the basic anatomy, but it's always worth going over and looking at the anatomy around the knee. Unlike the hip surgeons, it's very easy to do this lecture because most of the approaches are anterior. I wouldn't recommend you try a posterior approach on the knee. So what is the role of the incision? It sounds like a bit of a silly question, but it's worth just thinking about it. It's to expose the joint you're going to be operating on, the diseased joint, obviously. It's to allow you to do the relevant soft tissue releases to get the knee balanced. It allows you to make the bony cuts so that you can implant the prosthesis. And it allows you to implant the components through an adequate scar. So, very logical process. So, as I said, it's easy to talk about this because all the approaches are anterior for obvious reasons. You can go either medial or lateral to the patella, but if you look in the National Joint Registry, about 90 to 93% in 2012, they did a medial peripatella. There was a fashion, reasons of decreasing damage to the quadriceps, and we'll talk about that as well. But again, it's only about 1 or 2% in the National Joint Registry in the UK. So here's a diagram just showing you the knee with the skin and the fat removed. So you can see the traditional one. It's just a laser pointer here. Yeah. Down the middle, sort of the medial parapatella going up on the border of vastus intermedius through the rectus femoris there. And that's the extensile exposure I would guarantee that most people use. The advantage of it is if you need a bit more room, you can easily extend it proximally. The disadvantages are that you are compromising the quadriceps mechanism. So other approaches have been looked at to try and decrease damage to the quadriceps, so-called subvastus here, the mid-vastus here, and the mini-mid vastus, which is the one I use, where we just go into the mid-vastus medialis by about an inch and a half. If you go any further than that, it's if you go 2 or 3 inches into the vastus, you're in danger of compromising the neurovascular bundle and the vascular area around here. And you'll know you do it because once you do that, you suddenly get a bleed and you have to diathermy things. So we'll talk about the various approaches in detail in a moment. But these are your options when you're coming to do the medial approach. A lateral approach, obviously, is just an extensile approach on the lateral side, and probably most useful in the severe valgus knee. It gives you a very good exposure, and there's some evidence to show that it will improve your patella tracking. So the issue of the approach is a balance, really. You want to get adequate access that you can expose the knee, do your soft tissue releases, make your bony cuts accurately, and get the prosthesis in. But you don't want to damage the extensor mechanism too much. So you need to consider these factors before you make your decision which way you're going to approach the knee. Is there a pre-existing deformity? If there is, I would recommend that you err on the side of greater access. Look at the patient morphology. That's a very kind way of saying, is the patient fat? We can't say that in the UK, it's not politically correct. You must look at patella tracking. It's very important, as Jim said, with the x-rays that you do your proper skyline views. You need to know what the patella is doing before the operation, before you can judge how good your procedure is when you've finished the operation. If you've got patella tracking problems beforehand, you need to take that into account. You may do something different. Also, various approaches have been shown to have different amounts of blood loss depending how much muscle you cut. You're more likely to get more bleeding. And we found that some approaches do decrease the functional recovery and decrease hospital stay, which is very important in the UK because a longer hospital stay means it's more expensive. So this was the National Joint Registry in 2010. Medial parapatella was about 92% of all the total knees done. The mid-vastus, very small, and I'm one of those, 3%, and the others very small amounts as well. And that was over 80,000 total joints. So the medial parapatella, described many years ago in 1879 by von Langenbeck, as I said, it gives you excellent access, and if you need to extend it, it's just a matter of getting your scalpel and cutting more proximally. Downside, you may violate the patellar vascularity or the medial vessels coming from the anastomosis on the medial side, and the more you cut into the quadriceps, the less likely they want to work afterwards, so the patient complains of more pain. They find it difficult to do a straight leg raise early on. So let's look at the patellar vascularity in more detail. As you know, there's a very rich anastomosis of vessels coming from the femoral artery, going around the patella. And depending where you make your cuts, you will disrupt a certain percentage of that. So we do know that the medial parapatella can cause decreased vascularity of the patella. This may give you an increased incidence of patella fracture, although I have had much experience with that happening. It may cause loosening of the patella button if you do get avascularity, and I've had one case recently where I think that has occurred, and I should have picked it up much earlier. A patient who was getting a lot of anterior knee pain. I didn't resurface the patella in the first instance. Got a lot more anterior knee pain, and I thought to myself, well, it's because I didn't resurface it. So I resurfaced it. The patella came loose, and I redid that, and then it fractured, and I realized I must have given him an ischemic patella. And that's the only way I can describe what's been going on with him. So you need to consider the vascularity. Now, if you look at this through some of the studies that have been done, they've looked at this using scintigraphy, and they've shown that by doing a medial parapatellar incision, you do reduce the patellar blood flow by about 35%. But it does come back in time. This is made worse if you then do a lateral release at the end of the procedure. It's over 54%, and I'd say probably a bit higher than that. So I think if you do a medial parapatellar incision and a lateral release, there is a significant risk that you may cause avascularity to the patella. They found that without the lateral release, there was early revascularization over 12 months, and it was normal by 1 year. So whether it has a clinical significance or not is debatable. The southern approach, or the subvastus, which I did for a while, was developed way back in 1929, but it became more popular in the 90s by Hoffman, Ziggy Hoffman, who's a friend of mine, and he published a paper in Clin Orth. It does give you very good post-op recovery, and the patients can almost do a straight leg raise before they've woken up. It's so comfortable for them. The problem with it is the exposure, and if you get anything except for a small, skinny woman, it's very difficult to expose the other side of the knee. It's particularly difficult in the big, muscular male, and almost impossible to expose the other side of the knee if they've got fairly bulging quadriceps. So it is a useful approach, but I think it's restricted to a certain morphology, i.e. a nice thin person. So the subvastus was looked at compared to the medial parapatella, a randomized trial, 20 bilateral TKRs. It showed there was the strength at 1 week and a month. There was no difference after 3 months, but it was early results were better. It gave a much lower lateral release rate, and I found that using a mini mid-vastus as well. And the patients preferred the subvastus to the parapatella side, which they had done on the other knee. But the range of motion was no different. So good early results, no difference in the long term, basically. And this was shown in this other study by Royson and Oakley as well, single surgeon randomized. Earlier straight leg raising, less need for strong painkillers. Blood loss was lower. There was no difference in the hospital stay and no different functional scores. So some benefit in the early stages. And again, same in this study as well. I think the important thing is the fewer lateral releases. And I think in my practice now, doing a mini mid-vastus, I never do a lateral release. And I've got other ideas about that, which I'll talk to you later. Now, this is my little hobby horse about the patella. I'm a great friend of the patella. I know most knee surgeons consider it not very important, and it's the last thing. Oh, what should we? Oh, we better resurface the patella. Or no, I won't bother today. And so they do it. They usually freehand cut it, stick the button on, and that's it. I try to think a bit more about the patella. Now, most people doing total knee replacements evert the patella. How many people here evert the patella doing a knee replacement? You? The question is, do you need to revert? Why do you evert it? What's the reason you evert the patella? Right.
Well, no, but to get a good approach onto the market,
Yeah.
exposure, so that
You think you need to do that? Okay. Then what do you do in a revision knee replacement? How often can you evert the patella in a revision knee replacement? But don't you need good exposure for a revision knee replacement? And you can do it just by sliding it. You can do it in the primary just by sliding it. So my answer is that you do not need to evert the patella. Are there any downsides to everting the patella? Well, there has been some studies to show that by twisting the patella tendon and keeping it twisted for long periods can cause ischemia to the patella and give you a patella baha. Also, how many people have avulsed the patella tendon here in surgery? Come on.
I think revision surgery is not bad.
Right. The only way you can avulse, if you ever go in the cadaver lab, try and avulse a patella tendon. Now, the only way you can do it is by twisting it and everting the patella. You cannot avulse it by pulling it straight off. I challenge you to that. The only way you can do it is by twisting it. So if you don't evert the patella, you virtually have got no chance of avulsing it. So that's one good reason.
I think in a very, very fatty patients,
Mhm.
you put the patella in the fat, not to it.
Yeah, well, you can do it in any patient. Thin, and it just slides around the side very nicely. So my answer is, now, if you want to evert the patella, one thing you have to do is keep cutting the quads proximate. No, we're not quite there yet, a bit more. Oh, no, it goes over. So you cut the quads purely so you can evert the patella. If you don't evert the patella, you don't have to cut those quadriceps. So that was the basis of the big fad for minimally invasive surgery, say 10, 12 years ago, which went a bit crazy with quad sparing, I admit, but I use a mini mid-vastus approach and my incisions are a lot smaller and I don't cut into the quadriceps very much. purely because I don't evert the patella. So if you don't evert the patella, you find your incisions will get a bit smaller, you would cause less damage to the quadriceps. And it's just as easy. So that brings me on to MIS surgery. What about this? Well, if you look at the quadriceps anatomy, as I said, if you want to evert the patella, you normally have to make your cut up here somewhere so it will flip over easy. It depends on the size and the shape of the patient. So there we are, the medial approach. For MIS, you can do a mini mid-vastus here. That's usually enough. Or sometimes a bit higher up, depending on the attachment of the medialis. Or the standard approach more proximally. What's the advantage? Is there an advantage for MIS TK? Well, us surgeons that use MIS will say there is an advantage. It's less traumatic to the quadriceps, therefore applies a less physiologic challenge post-op when the patient wants to use the quadriceps. They get back to a more normal lifestyle a bit quicker, and we've now got new instrumentation which makes you easy to do this. How about the clinical differences? Well, the incision's smaller, you don't evert the patella, they get an early straight leg raise. Studies have shown that the range of motion returns more quickly, but in the long term it's the same. At 1 year the results are the same with the knee scores. The quadriceps snip, sometimes very useful, which you can do if you find it difficult to evert your patella. I don't particularly like using it. Insel described it. The instruments are much smaller so that we can get into the small wound. This is ridiculously small. It's not my case. It's probably an American. I once asked an American on a faculty, I said, "Hey, Chuck," whatever his name was, "what's the smallest incision you've ever used for a total knee?" And he looked at me, he said, 5 centimeters. 5 centimeters? I said, that's 2 inches. I said, "Are you sure?" He said, "Yeah." I said, "But the prosthesis is at least 7 centimeters big. How'd you get it in?" "Yeah, you have to stretch the skin." So I wouldn't recommend that. I think you have to be sensible. And the length of the skin incision is not the most important thing. Patients sometimes think it is. It's what you do to the quadriceps which is important. So the instruments are different. This is actually one of the nicest tibial guides I've ever used. It comes in from the medial side and it just fits on the tibia and gives you a very nice cut. Tibial preparation. See, once you've gone through the procedure, at the beginning of the operation you think to yourself, "I'll never get a total knee in through this incision." But by the time you get to putting the implants in, the exposure is adequate for you to prepare both the femur and the tibia and implant. And finally, it should look like that at the end of the operation. So it does cause less, I think studies have shown it does cause less trauma to the quadriceps. The patients do complain of less pain post-operatively, therefore they use less pain meds and can mobilize quicker. You do get less swelling, less bleeding. There's a slightly faster rehab, but at 1 year the results are the same. Now, when you come to do any of this surgery, you have to ask yourself, first of all, is the patient suitable for a total knee replacement? Or if you're going to use MIS surgery, is the patient suitable for MIS surgery? Secondly, are you a suitable person to do the procedure? If it's not anything more than a basic, easy, straightforward total knee with a problem, you might want to ask for help. You might want to refer it on to someone else. Do you have the proper instruments available? And it's up to you to check that in advance. Are your staff educated about how you want the patient to be rehabilitated and mobilized? And that's very important. And as Chim has already pointed out, it's very important that the patient knows what's going to happen to them from day one, what's going to be expected of them post-operatively with regards to physiotherapy, with regards to mobilization and pain control. If they know that in advance, they will accept it from you. If you spring it on them the day after the operation, they're going to wonder what's going on. Thank you.
I have got a question.
Yeah.
In the medial peripheral incision, the proximal part of the incision,
Yeah.
where do you like to put in the tendon or the vertical tendon junction?
What I do is, oh, I shouldn't have gone back. Let me go back. Right, what I do, I make my incision down here first of all. Oh, it's the wrong way. To about here. And now there's all the MIS surgeons classify the insertion of medialis as type 1, type 2, type 3. I think it's a bit of a silly classification. It means whether it comes in at the top of the patella or low down on the patella, or somewhere in between. The majority of the medialis inserts at about 2 p.m. on the patella. Some come in very high, and if that's the case, it's very easy to do a sort of minimally invasive incision because you just come up a bit further and slide it in just underneath medialis. So it's almost like a southern approach, and you do get a very good exposure. If it comes in very low, then it's sometimes difficult to do a minimally invasive exposure because you've got to come far enough above the patella even to slide it. So I come up to the top of the patella, and then I go into the medialis about 1.5 inches. And that's usually enough. If you go further than that, you're in danger of hitting the neurovascular bundle, and you may get some paralysis of vastus medialis post-op. So up, and then in about 2 o'clock, a small cut about 2 inches long.
My question is, the medial parapatellar incision,
Yeah.
the proximal part of the...
Here?
You go through the patellar tendon or the muscular tendon junction?
The junction, yeah. I try and avoid going through the patellar tendon if I can.
You go through the junction?
Yeah.
So, John, you won't leave, say, a 2 millimeter cuff of tendon for good suturing?
Oh, on the side of the patella?
Yeah.
Oh,
As you go further up.
further,
It-
yeah, I
it's
like to leave a
referring
little,
to the
yeah.
medial
I like to
parapatellar.
leave a little cuff, yeah. It gives you a better repair.
That's what.
Yeah.
I didn't got it.
So you've got to leave a cuff of tissue here, but when you go into the muscle, obviously you're going into muscle.
No, I'm talking of medial parapatellar incision.
Here, up here.
Go up.
Oh, I try and leave, well, I don't use an extensile excision, but if I did, I would go alongside the tendon and just leave a little cuff, a couple of millimeters, so you can get your stitching.
John, for the mid-vastus, or rather I would say for the sub-vastus,
Yeah.
have you found that this little bit of tissue here, that triangle
Yeah.
that you leave behind as you go along for the surgery, this
Yeah.
little bit, tends to become so
Dog-eared?
inconspicuous by the end of the surgery that you might end up actually, so I started, when I did a few of these, and I started doing a marker suture.
You can put it, yeah,
At the
it's
apex.
quite, so that you can repair it accurately.
Yeah.
Yeah, or either or mark it with a marker pen. Yeah, it's not a bad idea. Because then you get it aligned properly.
Yes,
Otherwise, you
alignment.
can end up with a dog ear.
Yeah,
Yeah, that's not good.
exactly.
That's not good.
So most of the time our digital nerve is being cut over there.
Sorry.
So there is a sensitive loss post-operative.
Yeah.
Most of the time because the digital nerve is being cut.
The recurrent, he's referring to the recurrent branch of
Oh.
which gives the hypoesthesia on the lateral side of your.
Which comes down here. Yeah, I think it's very difficult to spot it, and just keep your fingers crossed you will cut it occasionally. And a lot of patients do complain afterwards that they've got an area of numbness on the skin. I mean, obviously, why do you think they complain? Anyone? They all should get it in theory because the nerves come down as the blood vessels do from the medial side. So if you're making a cut through the skin, you're going to cut some of the sensory nerves. And I tell all my patients that they will have an area of numbness down here, which might be permanent, but usually it will come back. But I'd say in about 10% you can get permanent numbness, and you have to warn them that at pre-op, part of your consenting
In fact,
procedure.
we published a paper on that in the British Journal of Dermatology, wherein a certain percentage of these people at the end of 4 or 6 months end up getting an eczema-like reaction on the skin
Yeah.
as a result of retrograde axonal degeneration, and then they revert it back again. And it is often misinterpreted as nickel allergy during that few months.
I've got a case to look at when I get back. This is very interesting.
It's in the British Journal of Dermatology.
John, your MIS, do you not think you get more outliers in terms of alignment? Or not you, but
Some people do, yeah.
I think
This is where the balance comes between access and giving yourself a big enough incision to do the operation properly. When I teach on the MIS courses, one of the things we emphasize is that the most important thing is that you put the components in correctly, with good tissue balancing, with good bony cuts, so that align properly and the tissue balancing is correct, as you would normally. And the MIS is built around that, but you must not compromise those principles. And we show people how to do it through that incision.
Does anybody here do it?
So the MIS, I mean, I had one-to-one session with Priya,
Fred,
who
Yeah.
actually took this to the.
we actually put a trademark on it.
Yeah.
Did
they-
you noticed that.
But then,
Yes.
during that demonstration one-to-one surgical action, I found him leave behind half the meniscus, and then he just pushed it back.
Yeah.
And I said, what happens to that lump of meniscus that you just pushed back?
Yeah.
No, it doesn't seem to
Yeah.
bother anyone. And I don't think
He
that's
was the
right.
one that he tried to put, in fact what he put the trademark next was the quad sparing. If you see QSTM, that's Fred Trier. And he put his name to it, obviously to make some money. But actually we dropped the quad sparing because we realised, A, it was too difficult, and it was. I did about 30 or 40 of them, and it was a difficult procedure. And there was no advantage. There was no short-term advantage, there was no long-term advantage. And there were certainly more outliers.
You need the meniscus. The meniscocapsular fibers is where the pain is.
Yeah.
So you need the meniscus so you'll have persistent pain. And in fact, when I went back into a couple of my boss's patients, we took the meniscus remnant out, and it does not.
Yeah.
I don't think you need the meniscus.
No, you mustn't leave them this. But you must be very careful on the medial side when you're doing your approach and you're doing your the beginning of the medial release, which is very important. What I do is I use the border between the meniscus and the capsule as my line of dissection. But be careful that you don't stray into the MCL. I've done it. We've all done it, I suppose. It's very close there, and be very careful, particularly if you're using cutting diathermy, for instance, in that area. You can easily slide through it and cut through the MCL.
But MCL has to be elevated subperiosteally.
Yeah, exactly. I think if you're releasing it, you must elevate it subperiosteally distally, not cut through it, obviously. Not a good thing to do. To be avoided.